Hi, everyone. This is Bill McKendry, Executive Director of the Pennsylvania Healthcare Benefits Solutions Program, PHBSP. We help people navigate through the complexities of programs like Medicare and Medicaid and the private health insurance marketplaces. We provide individual counseling, patient advocacy services, and we produce community education presentations like the one you're watching now. This presentation was made back in October 2023, and its topic is how to effectively prepare for healthcare crisis events. I hope you enjoy the presentation. Hello, everybody. Bill McKendry, Executive Director of the Pennsylvania Healthcare Benefit Solutions Program. And today's presentation is certainly going to be about Medicare, but it's from a perspective that I don't talk about very often. Doesn't get much direction in this. Usually, my concentrations in Medicare have to do with the enrollment in and the selection of products within and the impact of those particular products on the access to healthcare in terms of quality and quantity. But often I tell clients that getting of the insurance, no matter how good that insurance is, it's still not enough if you are not familiar with and competent to navigate through the healthcare system. The assurance that the thing that you're attempting to utilize, this service, this product, in the healthcare system, just knowing that it's fully paid for even is not sufficient. You still may not be able to access this for various reasons, or what you're accessing is a shadow of what you expected, or just a taste of the quality of the service. And that's very much about being able to effectively navigate with the provider and coordinate your options most efficiently. And most people don't know how to do this. It's that simple. And it becomes most evident when we're talking about a critical medical event or a medical crisis. And so we're going to look at that specific aspect of accessing healthcare, and we're going to overlay it with the Medicare system specifically. Now, this necessity to be able to navigate through the healthcare system can occur well before you enter Medicare. It can occur while you're on an employer's health benefit. It can occur while you have your own private insurance product. But for purposes of today, and to keep it within a relatively tight presentational format, we're going to focus on the access of healthcare in a critical circumstance or a medical crisis when the individual is utilizing the Medicare system. So the premise is that the occurrence of critical health event or medical crisis, I'm going to be using these phrases interchangeably, they tend to be immediate and unexpected, and when they happen, they're pretty overwhelming. And especially if the individual or the individual's family hasn't taken any serious steps to prepare um, or how they're going to deal with a medical crisis. And they're not sure who to turn to when the crisis occurs, which, here, sneak preview, it's too late at that point. This is about doing the work well ahead of the occurrence so that you are prepared under the circumstances. And it wouldn't be necessary if we had a different healthcare system that was truly nurturing and user-friendly. We don't. And so we have to be our own advocate or know who we can rely on to be our advocate. So the question that starts this presentation is, if a medical crisis happens, are you prepared? And how do you prepare? What are the things you need to do ahead of time? And that's what we're going to carry through for the next hour and change. We'll examine how our healthcare system functions in dealing with extended critical patient care and the transition of a patient through the various stages of care. It's not a singular process. It's actually multiple steps. And depending on the patient's circumstances, those steps are going to vary. We're also going to look at the relationship between the provider, that could be the doctor. Most likely in this case, it's going to be a healthcare facility, a hospital, a clinic. And if we're talking what effectively is going to be acute care, at least in the initial stage, we're talking about a hospital. And the healthcare insurer. That insurer could be Medicare itself. The insurer could be private insurance. It could be a combination or coordination of multiple benefits. But how that relationship between the provider and the insurer is going to result in impacting the access to the quality and quantity of the services that this individual, this patient, needs, desires for the best possible outcome. And we'll consider the steps that individuals can take, should take, hope they take, to anticipate these kind of critical care events so they can have some control of the process to maximize the quality and quantity of the care they receive. So to focus this on a particular scenario, and one that, if not all aspects, a lot of the aspects should be something you recognize in yourself, in individuals you know, family members, friends. It's common. So Mr. Johnson is 73 years old. He's retired. He's relatively well-educated, an intelligent person, but he spent his whole life doing things professionally, personally, that didn't intersect him with the healthcare profession or the healthcare system. Currently, he's a widower. He lives alone. He has a couple kids. They're grown. One's got their family in Texas and the other's in Oregon. By now, his parents are both deceased. His siblings are all deceased. Clearly, what I'm creating is an individual who, based on various circumstances, is essentially isolated. And to make it even more, this is an individual that tends to be a solitary person. He doesn't have a lot of friends. none of them so boon companion that he can rely on them at the drop of the hat. But that's okay because he's reasonably content with his life. The mortgage is paid off. He owns his home. He has money in the IRA, and he lives modestly but comfortably um, with a combination of money from his Social Security and his IRA. His wealth is not immense, but if you took the market value of the house with the money on hand in the IRA, he's worth over $500,000. And he's, because he's a CPA, sat down and figured out how we can make this money last to a reasonable life expectancy. And fingers crossed, it'll still be there. And what he has going for him is he's in relatively good health. He's always been in relatively good health. No major health crisis, essentially ever. Not even any significant accidents or extenuating problems. He's lived, from a health standpoint, a reasonably blessed life. He's still the typical 70-something-year-old. His cholesterol's a little elevated, so he's taking a statin for that. And he's got high blood pressure, and he's taking a beta blocker for that. But other than that, he sees his PCP regularly. No need at this point to see any specialists. He exercises as a 73-year-old would do, and he's reasonably stable and reasonably content. Obviously, he's enrolled in Medicare. What he has in Medicare is going to vary throughout the presentation to make a point. But he for sure has Medicare Part A and Part B and something that enhances the Medicare Part A and Part B. So we're going to take Mr. Johnson through the process. First of all, we're going to send him to the hospital. One Saturday, while he's just puttering around the house, doing stuff, he likes to do his own maintenance, likes to garden, likes to just keep things clean and neat and tidy. He's that kind of guy. He has an accident. It's a significant accident. It's likely not life-threatening, but it's a big deal. It's a fall from a height in which it's clear some damage has been done. This could be for a 73-year-old falling down the stairs. This could be while the individual is doing something that used to be pretty simple and basic and something that one did in the normal course of the year, results in an accident for various reasons. And he could have been in his 30s or 40s, and it still happens. It's unforeseen, unexpected, but when it happens, it's drastic. And so that we don't have an immediate resolution, we keep him conscious, because if he was unconscious, they might find his half-eaten body by the raccoons days later. But we want to take him through the healthcare system. So, although he's severely damaged, he's able to reach out to 911 to get an ambulance to show up at his house. And this is actually the first thing to be thinking about in terms of crisis preparation. Where is the means by which you contact the emergency system to start the process? Where's your cell phone? Oh, it's upstairs. It's not going to do you much good now, is it? So do you just lay there and scream and hope someone hears you? One of the values of cell phones now is your telephone is potentially with you at all times. And as we get older, the I've fallen and I can't get up, I'll hit that buzzer. Well, the cell phone can be a reasonably efficient surrogate for that premise. That means you have to have the cell phone with you, charged, functional, essentially at all times. You don't have to, but there's the risk. So in this scenario, Mr. Johnson has his cell phone. He calls 911. He indicates what's going on. He indicates he cannot get up, or he's worried that if he does, it'll do even more damage. So he's just going to lay there and wait until the ambulance arrives. Now, while he's waiting there, what's going through his mind is, I'm likely going to be in the hospital. I have no idea what I've done to myself, but it seems to be serious enough. And now he starts thinking about all the things he should have done. He wishes he could actually and figuratively get his hands on at this point. But now it's too late. If your reaction to a healthcare crisis starts when the healthcare crisis starts, it's too late. Just lay back and hope for the best, because there's not a whole lot you can do at this point. He certainly could, probably will, call one or both of his kids. He might have a buddy somewhere that he lets know, but by the nature of not creating a structured, functional plan, he's at the mercy of the situation right from the start. So let's keep it going. They pick him up, stick him on a gurney, stick him in the ambulance, rush him to the emergency room. What emergency room? Has he thought through this? No, just whatever's the closest, whatever the ambulance decides to go to. And sometimes you don't have control. Depends on the day, depends on the time of the day. But he's the kind of guy that never thought in terms of utilizing specific hospitals for specific services, or understanding which ones are going to be better equipped than others, and for the possible things that are going to be needed in his case. So he's also at the mercy of wherever the ambulance takes him. When he hits the emergency room, obviously in this case, he's not going to spend time in the waiting room. He's going to go straight in to the emergency theater. And this is when the process of intersecting, I mean, it's already started when he made the call to 911. But his interaction with the institution effectively starts the instant he goes through the emergency room door. Admission documents are going to be prepared. A case manager is going to be assigned. A review of Mr. Johnson's insurance, the means to pay for this. And that also means who the facility is going to liaise with to talk about the expectation of the services provided and the reimbursement for the institution for these services provided. And to Mr. Johnson, this just all seems like a blur of activity. But divide the process between two things. One is the actual medical care. And we'll assume he's in a place where there is competent healthcare providers, that the facility is well equipped to deal with the situation, and it is not at a point of the day that it's overwhelmed with other patients, with other emergencies. But there's another parallel aspect that's evolving. It's the administrative aspect. And this is going to define ultimately the quality of care and the quantity of care that Mr. Johnson is going to receive. The case manager, to be less than kind and fairly blunt, has the job from pretty much the beginning of that gurney going through the emergency room door of planning on Mr. Johnson's exit from the facility. Sure, the case manager is going to try to navigate Mr. Johnson through the process and explain what's going on. But the case manager is ultimately not truly representing Mr. Johnson's interests. The case manager is representing the facility's interests. And if it's a healthcare system, of which the facility is part of, the healthcare system's interest. And a big part of that interest is to transition Mr. Johnson out as quickly as possible. Because the being in an acute care facility, what we call a hospital now, for an extended period of time is likely going to be the most expensive part of healthcare. I can think of a few others, but this is certainly up there. And if he's going to be in an ICU unit for an extended period of time, it significantly increases even that. How do we administer care to Mr. Johnson in, from one perspective, the most efficient way, from the other perspective, the least expensive way? How do we get out of this without spending a lot? Now, the institution should effectively not care, in the sense that our job is to make him whole as much as possible, to resolve his injuries, resolve his disease. And we're going to be reimbursed by an insurance entity. So let's do our best job, except that's not the reality. The reality is often the healthcare facility is part of a healthcare system, which in itself is represented by its own insurance arm. It's a closed loop. And even if not, even if the facility is not under that healthcare system, but part of that insurance providing network, the primary determinant is not the doctor, the hospital, the healthcare system even. It's the insurer. Not only at the instant Mr. Johnson hits the emergency room is there the doctors and the nurses and the healthcare professional staff. There's also the administrative staff that is immediately liaising with the insurance company. One of the first things they want to know is, what's your insurance, if they don't already know it. If he is a frequent utilizer of that healthcare system, they already know what his insurance is. So it's just a pro forma of going through his file. But one way or the other, very immediately, They're going to know that because very immediately they're going to be in contact with the insurance side of this process. And the insurance side of this process is going to have a significant impact. If the insurance is primarily through a private insurance provider. I'm going to talk about that in a bit. But knowing what his insurance is, who is the primary provider of that coverage, and past experience, significant past experience, liaising with that entity is going to be a determinant of the quantity and quality of care Mr. Johnson is going to get. So he doesn't know this. He doesn't realize this, but wheels are turning. Gears are meshing. The process is buzzing away while he's laying there and hoping to God that the doctor comes in soon, at least give him something for the pain. Right from the beginning in the ER, from the medical standpoint, determining his prognosis. And the more complex the injury or the crisis is, the more necessity for diagnostic tools, which could draw out the process. And most likely, especially in this case, I've set it up this way, compelling not just a stay in the emergency theater, but the necessity to admit Mr. Johnson so they can do more extensive diagnostics. The ideal would be to stabilize Mr. Johnson as quickly as possible, ideally in the emergency room, so they could say, "You're fine, we're going to discharge you from the emergency room." But the damage to Mr. Johnson's body is significant enough. And the fact that he can't get up off the table anyway is going to compel the facility to keep him for the length of time it takes to do the diagnostics and get a better idea, and obviously see what the extent of his capacity to function is. Now, a lot of those diagnostics are done while he's still in a bed in the emergency room. And they're going to do as much of the diagnostic process from that point. And if the results indicate the need for more diagnostics, or the results themselves of the emergency room diagnostics indicate the necessity to move him upstairs, euphemism for admit him as a patient for a period of time. And that's likely what's going to happen. It, again, is not the most desired. The most desired is, well, nothing that serious. We've stabilized you. Here's what you need to do. This can be done as an outpatient. We're going to discharge you right now from the emergency room. Good luck. Now, I'm forcing this scenario to compel the facility to move him upstairs. But through this process, the facility is talking to the insurer and explaining why it would be too risky from the standpoint of malpractice to discharge him prematurely. Doesn't mean that his stay is going to be long or the diagnostics are going to be extensive. It's going to be just enough to meet the standard of care required so they're not engaging in activities which could be later deemed insufficient and therefore malpractice. It's just enough, and the cost incurred is just enough. And over the shoulder of this process, if Mr. Johnson is using his primary coverage, private insurance, is the representative of the insurance company reviewing each and everything that's being done, and whether it's appropriate within the context of Mr. Johnson's situation. And what defines the insurance determinant of whether this particular diagnostic or this particular treatment or this length of stay is required is not a team of physicians sitting down and talking about the process. Unfortunately, it's determined by a computer algorithm. All of the insurance companies, the ones you would have, the ones before Medicare, the ones while you're in Medicare, if it is up to a private insurance provider to have control of the determination, the information about that patient is going to be inserted into a computer program by someone at the insurance end of things. And that information, based on the algorithm of the computer, is going to dictate what procedures, what length of time, and what follow-up to the initial level of care is going to be deemed acceptable and paid for by the insurer. And stepping outside of that zone compels the facility to either argue, which is usually a fool's errand, or, and this is an even bigger fool's errand, to provide the services without the assurance of the insurer. The facilities are going to stay within the scope of what the insurance company dictates is the acceptable care in this case for a person meeting Mr. Johnson's criteria. They're not going to look at Mr. Johnson, but they're going to look at Mr. Johnson's characteristics. A 73-year-old male with the following conditions, coming in with the following circumstance. This is what the algorithm says we should do. This is the extent of what is going to happen. And if you don't like it, tough. So from Mr. Johnson's standpoint, and within the context of his condition, what's wrong? What's the next step in treatment? How long? And just curious, what's this going to cost? But also then, where do I go from here in terms of the physical location of the care I'm receiving? What do I need not just now, but what am I going to need down the road? And what are my options? And if Mr. Johnson is unlucky enough to have chosen badly his insurer, he's at the mercy of the insurer saying, this is what you're going to get each step of the way. This is, or these are what the steps are going to look like. And the determination of these steps and the determination of this road he's going to travel is about the economics more than it's about the capacity to deliver a sufficient level of care. It's designed ideally to be the perfect balance, just the right care in just the right circumstance, to be as cost effective as possible. And that's what's going to be presented to the public. But the truth is, if you had to pick the superior determinant, it's the economics. How do we spend the least on Mr. Johnson that we can get away with? Because the more we spend, the less profit we have. And when I say we, I mean the insurer, not the hospital, not even necessarily the healthcare system. We are, unfortunately, an insurance-driven healthcare system. And to understand how one approaches preparing for crisis management, the first step is really the selection of the insurance. And that's going to be a determinant, not just when he's in the acute care facility. It's going to be what the post-acute care is going to look like. And there is a whole lot of options that Mr. Johnson's never going to be told about. Even if one of those options is very, very likely the best selection. Statistically, what happens significantly the majority of time is once Mr. Johnson has been deemed to be stable from the determination made by his healthcare review at the facility and liaising with the insurance company if he's using private insurance primarily. Once it's been determined he's stable enough to be discharged, he's going to be told by the case manager that here are his options. And the options generally are always home or to a skilled nursing facility. And the case manager at some point within the first few days is likely going to present to Mr. Johnson these ultimate options, because the case manager wants to start the process of transitioning Mr. Johnson. So the kinds of questions they're going to be asked, and the ideal is send him home. Perfect solution from the standpoint of the insurer and from the standpoint even of the healthcare system being subordinate to the insurer is discharge him home. And it's up to Mr. Johnson to understand what that's going to be like and be prepared to push back with the expectation that I don't think this is in my best interest. Over and over, I'm compelled to deal with individuals that have been told they're going to be sent home when there is no way that being sent home is the best outcome for continuation of care. So Mr. Johnson is going to push back if he's capable of, if he's compelled to understand that this is not in his best interest. If the push is, would like to send you home, wait, I can't walk yet. Well, that's okay. We'll get you. No, it's like you won't even get me into the house. To get into the house requires going up 12 steps. And then to get to where the kitchen is another 12 steps. And to get where the bathroom is another 12 steps. You can't walk, let alone climb stairs. Now, how am I supposed to do this? And I don't have, well, what about your what? Wife, children? No. Support system? None. Force the facility then to deal with the actuality, as opposed to, well, I guess you know what's best. No. Well, they do, but not in your case. In the case of the payer, the case of the institution moving you to the next step and being done with it. And if it means that there's a good likelihood you're going to return within a short period because they're already in motion to discharge you. And it doesn't have to be with a bodily injury. One of our own on the board was discharged prematurely with a raging 100 and something fever because it had already been determined that she was to be discharged. And the on-duty staff said, this is not a good idea. But hey, powers above us have said discharge her. Within hours, she returned to the same facility. Septic. Had she remained in, they would have been able to monitor this. Had she not gone back within a timely period, she probably would have died. So something as obvious as this person is running a fever of 103, this is not a good idea to discharge from a reasonably functional and competent facility. Is not outside the norm. And depending on how the individual, or if the individual is incapable, how the family pushes back. And that doesn't mean that they're going to be successful necessarily, but at least they're not acquiescing. And part of the other problem is most individuals do not know alternatives to the we're going to send you home and we'll create some kind of home care regimen as a follow-up, or outpatient care as a follow-up, or, oh, we will send you to a skilled nursing facility. There are various other alternatives that are more likely in this scenario going to be way more effective. So if Mr. Johnson convinces the case manager to convince the care team that home is just not within a reasonable expectation, at least for the current situation, the next step is, all right, we've come up with a half dozen skilled nursing facilities. Because they're the best? No, because they're the easiest to transition Mr. Johnson to. The case manager knows they've got beds available. They know that from past experience, the process is the easiest. Here's 6, pick. Mr. Johnson likely doesn't know anything about any of these facilities, the context of their quality, the context of the kind of care facilities they have for his unique situation. He's not had to deal with this in the past, so he's not been compelled to become at least familiar, let alone adept at understanding what these facilities do and how each is uniquely equipped to handle this. And if there are other alternatives. Now, if Mr. Johnson's injury is so severe that he can't walk, so severe that he's not even conscious, that he's in a coma, sending him to a skilled nursing facility It's going to serve no purpose. And very likely, his stay at the skilled nursing facility is going to be limited to just a few days, because the report the skilled nursing facility is going to give to guess who, the insurer, he's not improving, or the arc of his improvement is minimal. And the insurance is going to say, well, then discharge him, send him home, or send him somewhere, but not in the skilled nursing facility that we have to pay for. And again, the goal is get him home. Because home is best? No, home is cheapest. And I have seen it numerous occasions where the utilization of the skilled nursing facility transfer is to simply get them out of the acute care facility, so they're off the back of the acute care facility, and now it's the problem of the skilled nursing facility, and still ultimately being controlled by the insurer if the primary coverage is private insurance. And again, a new case manager, a new round of determination, a new group of healthcare experts being guided by the insurer, come up with a resolution at the skilled nursing facility. Skilled nursing facilities are often misused as the way to simply get them out of our place to some other place, and also the stay in an acute care facility can be unlimited in terms of what the insurance is required to cover. Theoretically, don't ever expect this to happen. An individual can remain in an acute care facility for years. And as long as there is the acceptance of the necessity to care for this individual in an acute care facility, the insurer is on the hook for an unlimited time. But if we can transition the individual to a skilled nursing facility under Medicare, this sets a clock running. And honestly, even in a non-Medicare coverage, the extent of stay in a skilled nursing facility, another word for that would be rehab. But it's a bad use of the word. You'll see why in a minute. So I'm going to keep using skilled nursing facility. The limit of time there is 100 days. Once that 100 days has been met, even if there is necessity for continuation of rehabilitative service, even if that rehabilitative service seems to be doing some good, it's an absolute line. Arbitrary, 100 days, why not 110? No, why not 80? Once the 100th day is reached in an unbroken sequence, that individual is automatically presumed no longer to be primarily in need of health care and is now recategorized as being in long-term care. And thus, the healthcare system of coverage, whether it be Medicare, whether it be private insurance, whether it be group plans provided by the employer, or private insurance you buy in the marketplace before you reach eligibility for Medicare, any of the possibilities. After the 100th day, they're done with you. Either go home, or if you stay, you're staying in a personal care mode. And for the length of time, a long-term care mode. And the paying for that is completely different than the expectation of health insurance covering. And the sad thing about the fight that families do to maximize as much time in skilled nursing as they can, the fight's to get as much of the 100 days as possible. And they're not even aware that, well, they're kind of aware, but not fully of the impact of that, that even if you win, even if you get to keep mom in facility for the entire length, once you reach the 100th day, it's all over anyway. That's all you're fighting for. Give me as much of the 100 days as possible. Once that's reached, the individual is now deemed to be in long-term care, even in the same facility, even in the same regimen. The import of that, the semantics of that, is the health insurer is now resolved the responsibility of what it costs to be in that facility. And that is a huge determinant. But there's something more important, and I'm backing up from just the economics of that 100-day limit and what happens after that. Even before you set foot in the skilled nursing facility, to utilize the best strategy for the level of care that individual needs, I think it's imperative that that individual or the individual's family understands the other options. There are certainly more options than either go home and try to carve out some kind of care strategy at home or transition to a skilled nursing facility, which is typically the two options the individual's family is given. Here's just a couple others, and two very important others. If the individual is still in need of significant acute care, and I see this often when the individual is comatose or the individual is so badly injured that they're incapable of doing basic activities. The response of the acute facility, the response of the insurer is, well, then, okay, we'll send them to the skilled nursing, but honestly, what we really are going to be doing is preparing this person for long-term care, some type of personal care setting, either at home or in an institution. It's like, wait, there is an alternative. There are facilities that are designed for an extended care process under the definition of medical care. Now, you cannot allow the individual to be transitioned to skilled nursing because that starts a 100-day limit. You want to keep the person in acute care as long as possible because there is no limit. And so if the acute care facility, the hospital says, but not here, all right. And we understand you're not really designed any longer. It used to be simple. There's hospital. Hospital was acute care. Hospital was rehab. Hospital was all things. We've compartmentalized the care. We've specialized the care. Partly for the quality of the specialization and partly for the economics. We can call this a skilled nursing. We know we've got a 100-day clock ticking. There are facilities called long-term acute care facilities, abbreviated LTAC. They're hospitals. They're not skilled nursing facilities. They're not rehab in the sense of the 100-day limit applies. They're hospitals in the sense that there is no limit. the individual can be in an LTAC as a patient for months. I've had multiple patients, because they were able to fight the transition instead of a skilled nursing facility or being sent home, to transition into an LTAC. They were able to utilize the LTAC's quality of service to maximize the level of care for an extended period of time. So what's the problem? Why aren't more people in LTACs? Because private insurance is loath to utilize that option. It's expensive as hell. And the care team at the acute care facility is often reluctant to push back for various reasons against the insurer. And often it requires a demand to do what's called a peer-to-peer consultation. And sometimes it's a three-way peer-to-peer-to-peer. It's the care team at the acute care facility talking to the physicians, the healthcare specialist representing the insurance company, and bringing in the individuals representing the LTAC to talk about, under these particular circumstances, what's best. But if the patient doesn't know this option exists, the case manager is not going to come in and say, well, there's skilled nursing, but you know what? There's this other thing called long-term acute care. Let me tell you what it does. Whoa, that's what I want. Well, the insurance is not likely going to approve it unless we do a peer-to-peer. Do that. The case manager is going to get dropped in a vat of acid if he or she makes that their normal protocol for dealing with patients. Yes, the case manager would be required to explain. Yes, even a case manager would be required to explain that patient can shut down the discharge process by asking for an appeal, but this is not going to be the primary way that a case manager is going to counsel. And I have seen it, I have experienced it, where the case manager says, you don't want to ask for that, you're not going to get that anyway. Really? You're so optimistic about this. I've done this for 20 years and no one ever gets this. Well, stand over there, watch, and you're going to see maybe the first time in your life this occurring. It requires the patient has to be diligent and adamant and use every device they have within the administrative process to their advantage. They also have to establish as quickly as possible a good relationship with their care providing team at the acute care. Ideally, doctors they worked with in the past, ideally specialists that they've utilized. Well, unfortunately, Mr. Johnson's health has been so good, ironically, that he's not developed the kind of relationships with orthopedic surgeons and neurologists and the other kinds of specialists that are going to be brought in. This is a brand new experience, and he hasn't developed the relationship, nor does he know that he may have to utilize them to challenge a discharge to where the facility would like to discharge him to, or where the insurer would like to discharge him. And if he's going to be in a fight to access something like a long-term acute care facility, he's going to need allies. Or just to stay in the acute care facility a bit longer, he's going to need allies that are going to represent in this peer-to-peer and be willing to go to battle on his behalf. As an alternative to an LTAC, which is designed for individuals that are so acutely in need of medical care, they're not ready for rehabbing, and they're certainly not ready to be sent home, but the normal acute care facility is also not likely the best place for them either. There's another alternative. They're called rehabilitative hospitals or rehab hospitals. They're hospitals. There is no limit to the length of stay. And they're designed to be this hybrid of an acute care facility, which has a heightened capacity to deal with the medical issues, but also significant rehab capability. The rehab capability of these rehab hospitals absolutely dwarfs what most skilled nursing rehab capability offers to patients. If you're going to be in serious rehab, if you have a serious injury, a serious incapacity, you do not want to be sent to a skilled nursing facility. You want to fight like hell to go to a rehab hospital, which looks like, if you didn't know the difference, would be confused with a skilled nursing facility. But it is significantly better equipped, better designed, better administered for a longer stay, a more intensive level of rehabilitation. Here's an example. At a rehab hospital, individuals are likely to get somewhere in the neighborhood of 4+ hours a day, 7 days a week of intensive rehabilitation. Now, you have to be in a rehab process. If you're not ready for rehab, you're going to be discharged real fast from there as well, because you're not able to engage in the rehab regimen. So back again, maybe the better solution for the time being, the long-term acute care until this person is better healed. And at that point, once the individual has transitioned to a rehab hospital, they should be expected to undergo regularly intensive rehabilitative care, and often with a one-on-one physical, occupational, and speech, if necessary, therapist. The patient to therapy ratio is incredible, typically 1-to-1. And the amount of time spent in rehab is significant. The typical skilled nursing has neither the equipment that a rehab hospital does, nor the number of qualified therapists. Often there is a licensed therapist and assistant to that individual carrying out activities. And even then, in 1/4 to 1/5 of the amount of time that normally is allotted in the rehab hospital. An hour or two a day in a facility that has limited equipment, and usually a therapist or an assistant to the therapist handling 4 or 5 patients at a time. So even within that hour or two that the individual is assigned, they're getting not the kind of personal rehabilitative attention that they would in a rehab hospital. But again, if Mr. Johnson didn't make the effort to understand, and he didn't feel compelled to up until the accident, up until it became a personal thing, he's not going to know the difference. He's not going to know that such things exist and the quality and capacity. And he's not going to understand that if you're in a skilled nursing facility, there's a 100-day limit. If you're in a LTAC or rehab, you're there until you've maximized your rehabilitative capacity. It's a different outcome, and it's a different approach. And even when the individual goes home, whenever that is, There's also understanding there are levels of care. If the individual does go home and cannot take care of themselves, there is the necessity to bring personal care to the home. And if the individual needs medical care, to have that care brought to the home. But here's the problem. It's engaging to have those services brought to the individual's home by home care providers. And the problem with many geographic areas is there's just not enough home care providing companies to facilitate the needs in that area. And that was acutely demonstrated during the pandemic, when individuals that were receiving personal care services at home and even medical care services at home were told that those services were being drastically reduced and often cut completely because they couldn't get care providers in that geographic region to take on more patients or to even continue with the patients they had. And so what the individual or the family was faced with is, you risk trying to survive with significantly reduced levels of service, or you go into an institution. Oh, a hospital? No, not quite. A long-term care facility or a personal care facility of some kind. So often individuals going home with the expectation that, all right, the care will be delivered to my house, with the promise made by the facility, oh, here's some home care services to reach out. Finding out only after they've been discharged, after it's too late to react within the acute care system. The number of hours, the level of service, the quality of that service is far less than they were led to believe. And now they have to make the best of it. And even if they get a level of service that they seem to be satisfied with, there's no guarantee that'll continue. It could be discontinued because the insurer says you've improved enough. Or more likely, yeah, you probably could use it, but we just can't find anyone within this area that's willing to provide the service. So sorry, force majeure, forces beyond our circumstance prevent us from fulfilling the necessity of providing you that care. So here's the alternative. Go into a nursing home. How about going back to a hospital? No, that's not an option. Here's some nice nursing homes you might want to consider. And ultimately, it is important to consider that if this condition that put Mr. Johnson in facility was in fact terminal, there may be the necessity at some point to consider palliative care. Another transitional tool is hospice care. Hospice delivered in institution, hospice institutions, not acute care, or more likely delivered at home. But understanding when and how to use hospice is in itself. Now, very often acute care facilities are going to leverage hospice care as another way of discharging the patients. And very often it'll be the case manager that introduces the family or the patient to a hospice care representative. Sometimes it's a valid option. Sometimes it's just a way to push that patient outside their scope of necessity, dump them on someone else. And understanding the capacity and the limits of hospice care are essential Again, it often strikes me in observing the process that this is less about explaining, educating, informing the individual or the family as to what the options are of any of these, skilled nursing, hospice, any other alternatives, than it is just make a decision. I've got other patients. I've got other things I have to do. Either make a decision or we'll make one for you. And it's unfortunate. It's not just that the facility is compelled to move you along. It's that the person who should be your guide is so overwhelmed and so compelled by their boss to move this thing along and get a resolution, get the person to sign the documentation so we can start the discharge process. And what are you waiting for? You've got 6 other patients you've got to deal with. Part of that is reflective of healthcare institutions finding ways to cut costs to their institution by reducing certain staff functions. And typically, one of the areas that takes the hit more than usual are case managers. And the way they resolve it is just add a few more patients to the existing case managers until the point of the amount of time and the amount of attention that a case manager has to pay, has the ability to pay to a patient, is limited. And they're stressed and they're trying to move the patient along. And there is that perceptive resentment that questions and concerns simply eat up that individual's time where they could be moving to the next patient. And it's unfortunate. And it's up to the individual patient and their family to dig their heels in and say, I still have questions. I still want to talk to you. No, you don't get to go. The goal from the case manager is, let me get out of this room so I can get to the next room. Let me get you to sign the paper so I can get you out of this facility. Your job as the patient or the patient's family is to say, whoa, stop. I don't understand. I don't know. It's still not clear. You're not doing a very good job of explaining. I feel like I'm being hustled along. So I'm going to slow the process down. I don't sign anything. I don't agree to anything. I don't do anything until I feel more informed and more comfortable about it. And I strongly recommend ownership has to come from beyond the expectation of what the facility is going to provide you, and taking ownership within the context of your own care or the care within your family. So what are the things we need to do? What are the steps that any individual has to take some responsibility for, should take some responsibility for? It starts with insurance. The choices that an individual makes, if they have the ability to make choices, will define the capacity of utilization of healthcare services in a medical crisis. Insurance is the starting point. And it's well before we get to that healthcare crisis. If we're waiting for that to occur, it's too late. So, since we're focusing on Medicare, because that's what I want to do, and by now, hopefully, you guys know the drill, that the inherent nature of Medicare is it's made up of multiple parts. The basic Part A, Part B are designed to cover a significant part of the services deemed to be inpatient or outpatient. But Part A and Part B alone are never going to be sufficient. They're going to impose deductibles and co-payments. And the necessity to cover those costs is going to compel a reliance on private insurance, either to supplement Medicare or to replace Medicare. And by now you should know that all of the products that exist within the Medicare universe can be assigned to the category of a supplement to Medicare, a Medigap, or if an employer is providing it, typically they're referred to as Med Sups or Medicare supplements. They may instead rely on a private insurance product that replaces Medicare, an HMO or a PPO product. And they're also going to likely obtain either separate from the Medigap or as part of the Medicare Advantage package, prescription drug coverage. Those are the inherent definitional components under the Medicare system of the various private insurance options. Things that cover other kinds of services like dental and vision, they're outside of the Medicare scope. They may be offered by Advantage plans. They may be obtained separately in addition to supplements, but they're not normally part of the Medicare system. And for our purposes, we're just going to focus on the definitional medical services covered by Medicare, either as an outpatient or an inpatient mode. You've seen this before, but the capacity of this chart is to indicate which insurance option is going to work best. And it's not necessarily apparent. And it certainly doesn't reveal itself even when the individual is utilizing it. They just don't know any different. So here is the wisdom. Option 1 requires the utilization of Medicare A and B, the government portion of Medicare, as your primary coverage. When an individual is using option 1, the healthcare provider submits the request for reimbursement to Medicare, not to private insurance. And they submit it after the services have been provided. If Medicare approves, Medicare then sends the approved determination to the supplemental private insurance. The supplemental private insurance now knows it's been approved. And once it's been approved by Medicare, the supplement cannot turn it down. They simply pay the balance that they're compelled to pay. This is important. It takes private insurance out of the equation of making the determination of what to provide, when to provide, and how to provide. They are to supplement. The determination of whether this is acceptable or not is exclusively within the realm of Medicare. Part A for inpatient, Part B for outpatient. And it's determined after the fact. Medicare is not liaising with the healthcare team on a day-by-day basis. They're not second-guessing, overruling. And this gives the institution and the individual care provider professionals greater leeway in making determinations. Now, Medicare institutionally is not Father Christmas. They're not going to have unlimited access to all the services that can be dreamed of. But the facilities are aware of the extent of the capability of utilizing Medicare itself, Part A or Part B. And every provider I've ever talked to over the last 2 decades has without a doubt assured me that they would rather any day deal with the expectations of Medicare Part A or Part B covering this than having to intersect with some liaise from a private insurance dictating what they provide for their patient, how they provide, and when they can provide it. And often we see the value of Medicare A and B at a Medigap in terms of, oh, you can go to any provider. Fine. Nothing wrong with it. And once you get there, the entire cost is paid for. Also great. But there is an unrealized third element that in this case, for this presentation, is critical. The expectation that the determination of the quantity and quality of care is allowed to rest far more with the care providers than with the insurer. Option 2 turns that premise on its head. You guys should know by now that if you are enrolled in a Medicare Advantage plan, a Part C plan, a private HMO or PPO product, you've abrogated the utilization of Medicare A and B. Medicare A and B are no longer essentially covering any part of that individual's health care. It's exclusively within the realm of the private insurance HMO or PPO. And they're dictating where you go by their network and what you get by the necessity of, if not prior authorization, a continuum of observation, the process, and insertion of their determination whether this direction of care is acceptable. For all intents and purposes, the care assignment and care management is really dictated by insurance companies and not by the facility and not by the team. To some degree, they can push back, but not often. And ironically, it's not a team of doctors at the insurance company. It's an entity that has inputted the data of that patient into a computer program, and the result is based on our algorithm. This is what the patient should receive. But this patient's not exactly that kind of 73-year-old. This patient is different, not our problem. We're looking for an acceptable level of care that keeps us from risking malpractice and yet minimizes the costs to the entity that we represent, which is not in the best interest of the patient. It might be valid to the patient, but that's a tangential. That's beside the point. And so when Mr. Johnson is laying there, waiting for the ambulance, Mr. Johnson is thinking 2 directions. If Mr. Johnson is experienced enough to imagine this, oh my, I probably shouldn't have picked that HMO. It was nice because the premium was 0 and I got all sorts of swag with it, like some free vision and free dental and health club memberships. But first of all, I'm going to have to pay some cost to be in facility. Worse, I don't know what the quality of that service and the duration of that service are going to look like. It's certainly going to be less than if I had selected option one. The good news, if Mr. Johnson had selected a Medigap to supplement Medicare A and B, is wherever I go, that facility is very likely going to take Medicare. Certainly, they're going to take me because I have Medicare A and B. And I know the cost is going to be zero because between Medicare A, or if I'm an outpatient, B, and my supplement, the entire cost of service is paid for. One less concern that I have. But the other underlying is I have a better chance of a longer stay in facility, a better chance of navigating to a long-term acute care facility if I understand what that is, and this is a better fit, or a longer stay in skilled nursing. And the kinds of services I can secure in an outpatient format for therapy or for home care because I'm still not able to get out of the house. All of these things are enhanced, improved by relying on Medicare A and B. It was money well spent, Mr. Johnson would say. But the problem is, Mr. Johnson has to know that before the crisis. He has to have prepared himself when he went into Medicare in making these decisions, anticipating if this happens, I've got it covered. What else does Mr. Johnson have to be considering well before the crisis? Well, here's just some practical things. I'm about to take a trip to the hospital without much control over the process. What information do I need to have? Where the hell is it? Where's my insurance cards? Where's my list of medications, if I'm taking any? Where's my list of physicians and their contact information, my pharmacy and its contact information, any other healthcare providers and its information? What about my family members and their contact information in case the facility needs to contact them? And please, God, let me stay conscious so I can at least alert the people from the ambulance about where this stuff is. If not, where is it in an accessible place? How do I communicate to the first responder where to find this stuff? Or just contact a person? Do I have a person that I've designated to be the contact? Listen, in case something happens, you probably are going to get a call. Maybe that person is just an informal relationship. Maybe that relationship is very specific. Maybe that individual has been designated your healthcare power of attorney for exactly this kind of situation. And this individual is your healthcare advocate for exactly this kind of situation. Where's my will? Who's got a copy of it? Oh, shit. Where's my advance directive? Because this might be terminal. You never know. Who's got that? Where are the copies? Who's got them? Where are they at? What if it's not at home? What if I'm in transit somewhere? Where's the stuff in the car that's going to alert the first responders of all these things? What if it happens on my person? I'm shopping. Where do I have it so they're going to be able to identify enough information that they can start contacting? And maybe that contact will reveal all the other stuff, but I need a contact then. Have I worked this out? And what about essential pieces of equipment? I've already mentioned it becomes a heightened need to keep means of communication with you at all times. A cell phone. It's the great thing about the cell phone. It's portable communication. But don't forget, if you go to hospital, you're going to be there for an extended period. And what about a cell phone charger? And how is my support system going to enhance those things I need and additional things I'm going to need for an extended stay within the healthcare system? Who have I designated to take care of the things that need taken care of? Have I sat down with someone and said, in case this happens, will you pay my bills? Will you collect my mail? Will you watch out for my house? Will you come in and feed the pets? If I'm there for an extended period, will you bring me fresh pajamas and the other stuff, my laptop, my whatever? Typically, when we're young, that's what mom and dad does. And when we're married, that's what our spouse does. But what happens when mom and dad are dead? What happens when spouse is gone? Or we never had a spouse to begin with? What happens when, as we age, we realize how isolated we are? And those things that we've gotten used to being independent and capable of doing, we're no longer capable of doing. And they still have to be done. Who's going to do them for us? Have you worked out that relationship? And is the person that you're relying upon dependable? Is that person going to be around when the crisis happens? And who's your backup in case that person happens to be on vacation, happens to be themselves incapacitated? And whoever that person or persons are, do they have access to the necessary info that you're going to have to provide to the facilities? Because you didn't bring it. You don't even know where it's at. Multiple copies of your insurance cards, multiple copies of your medication list, updated, obviously, multiple copies of who your physicians are, multiple copies of everything distributed to individuals who have them, that just in case no one can find it anywhere else, at least if they can find something that says, in case of an emergency, call this person. Okay, that person will reveal all. But you have that person. Is that person contactable under the circumstance, in the immediacy? Have you worked out all the details? Have your directives, care been explained sufficiently to that person that they know what needs to be done, what you want, and especially if the healthcare crisis has the potential of turning terminal? The other thing you need to consider, at least in the first instance, creating your support system, that should be done inherently by everyone. It should likely also be done by everyone as they reach a certain point in their life. They establish some relationship with an attorney for the purpose of certain documents, at least. The goal of working with an attorney, meeting with an attorney, sitting down, is to create a process by which your goals and priority for the rest of your life. Well, what about financial plan? No, this is different. Yeah, nothing wrong with the financial planner, but the financial planner is looking at it from a different perspective. The estate attorney, better would be the elder law attorney, is compelling you to engage in a conversation about what your personal goals for the rest of your life are and how to prioritize them, and to identify potential issues and problems in achieving those goals. What do you want the rest of your life to look like? Paint me a picture of what the ideal transition from where you are right now when you pass away is going to look like. And my job is to tell you within the scope of what you want to accomplish, these are the issues that you could run up against. And how do we prepare for those issues and problems? How do we reduce possibility of mistakes being made, of problems arising, and surprises that you're not prepared for? Ideally, we want to prepare you for everything. Ideally, we want to make sure all contingencies are covered so that we lessen the impact of your aging process from a healthcare and personal care standpoint, and lessen the impact of potential medical crises from taking you by surprise and overwhelming you in the scope of what's needed. There's certain documents that you're just going to inherently at least consider, if not commit yourself to having done. A couple of them I'm going to mention. There's two I'm going to be more emphatic about. Not that two are more important than the other two. They're all critical, but today's about healthcare crisis. So one of the documents certainly is your last will and testament, and possibly also creating some form of trust, a revocable or irrevocable trust based on what you want to accomplish, based on your goals and the potential problems interfacing with that. To make sure you have a support system, you're looking at the creation of a durable power of attorney for someone who can act on your behalf because you don't have a spouse. Your kids are out there. And, I was thinking of making the kids, they're in Texas and Oregon. Is that going to be the most efficient? Maybe that's the only choice you've got. And maybe they're not necessarily the best, but they may be the only ones you've got. But the attorney will also say, look, let me give you some other alternatives that you weren't even thinking of. So part of the attorney's job, if the attorney is a good attorney, is to tell you things that you're not even aware of, to tell you what you don't know about, because you don't know what you don't know. And also, and this is what I'm going to spend more time on, creating the advanced healthcare directives, the healthcare power of attorney, as opposed to the general durable power of attorney and the living will. So in quick, the last will and testament is a written document that expresses the directives of the individual, that in the event when that individual dies, it directs how that individual's assets, their estate, is going to be disposed of, and appoints a personal representative, not someone during their lifetime, but someone that goes into effect once they pass away. That person's either an executor, male, or executrix. Executors tends to be a gender neutral term now. And that person is tasked with the responsibility of disposing of the assets, disposing of the estate, wrapping up the estate issues. Also common, goes hand to hand, hot dog and mustard, is the general durable power of attorney, the POA, often. It's also a written document in which the individual appoints and empowers a representative. Individual could be a institution of some kind, to make decisions and engage in transactions on behalf of the individual in the event of the individual's incapacity. These are the two ones I want to emphasize a bit more for today. The healthcare power of attorney. Take it for granted these are all written documents. This document appoints and empowers a representative specifically to make healthcare decisions on behalf of the individual. If, backing up, the general durable power of attorney is about making financial decisions, paying bills, doing banking transactions, purchasing or selling assets. The healthcare power of attorney is empowering the individual to make decisions regarding that individual's health care, representing the individual in the acquisition of insurance, the utilization of insurance, the acquisition of specific levels of care. All of those things when the individual lacks the capacity to do so. And most importantly, it permits the representative who has the healthcare power of attorney to receive healthcare information about the individual so that it's not in violation of HIPAA, so that the healthcare providers cannot say, oh, I can't talk to you about this because that would be in violation of HIPAA. I have healthcare power of attorney. Oh, okay, well. The healthcare power of attorney is empowered to begin or stop, withdraw or approve medical treatment, be responsible for admission or discharge into a facility, and interact with providers and insurers under the HIPAA rules. For the person who is incapacitated, having someone who has that power to represent them is an important capacity to say, from now on, talk to that person. He has my power of attorney to represent me in healthcare matters. And sometimes it's not even a question of incapacity, or it's the lessened capacity because the individual is an inpatient. And it's the ability to say, this person is empowered to make decisions for me because I inherently trust this person's capacity. And typically that person is going to be someone who also is aware of what the individual's healthcare directives are going to be. That person who has healthcare power of attorney has had long conversations with the individual about what happens when, what happens if. So they're fully aware of what their responsibilities are and what the scope of fulfilling those responsibilities on behalf of the individual. But to make sure there is no question, the individual, in addition to creating a healthcare power of attorney, is also going to create a fourth document, the living will. It's going to provide instructions, explicit instructions, regarding the types of medical care that the individual does and does not want, especially in the case of terminal and end-stage medical circumstances, when that individual cannot communicate their own wishes. So if the individual, if Mr. Johnson is conscious, functional, this living will is not necessary. He can communicate himself. What if he's in a coma? It's like, well, what about the spouse? The spouse may not be the person best capable of communicating this. The document should be the most imperative for laying out in detail, and not just a couple pages, not something that you can whip off of the internet and fill out. I have a living will, and it's nearly 20 pages long. It's broken down into specific circumstances, specific scenarios and criteria. And it clearly delineates, based on those kinds of circumstances, what I want done and not done. And I have to make sure my healthcare providers have access to it. It's no good if it's in a drawer somewhere. And where the hell did I put that? Oh, geez, I can't remember. A copy should be available with your current healthcare providers. A copy should be available with your, if you have one, healthcare power of attorney. A copy should be available with family members. All of these things we've been talking about should have multiple copies. And if you update them, update the copies. Make sure there's not contradicting copies floating around. Now, you don't have to do any of this stuff. You can be the typical person going into the circumstance, hoping, please, I hope everything works out. Or you can take control of the process. It's up to you. You can do some, you can do all. And it's a very uncomfortable, because especially for the living will, especially for the healthcare power of attorney, it anticipates the deterioration of the individual's capacity to be independent and self-functioning. It recognizes their limitations. It recognizes ultimately their demise. It's not the easy conversation to have with anyone, and certainly with families. It's, well, this Thanksgiving, we're going to do something that no one's going to like, but we have to do it. Let's gather around and let's talk about what's going to happen when. Oh, Dad, it's like, look, we have to face a certain inevitability. And if we don't, the bird's going to fall on somebody that's not prepared for it. And so I'm doing this for me, and I'm also doing this for you guys. And here's what we're going to do. But part of that should be facilitated first by sitting down with a specialist, an attorney, but not just an attorney. There's another aspect to this, but certainly meeting with the attorney, a competent elder law attorney. Oh, this attorney also does DUIs and whips up real estate transactions. No, you need a type of attorney that specializes in this kind of stuff. That's all they do. And their attorneys literally call it certified elder law attorneys. I'd recommend that's who you seek out. But there's somebody else you seek out. They're healthcare advocates or patient advocates. Perfect solution is in the lawyer's office. One of their staff is a healthcare or patient advocate. What do they tend to be? They tend to be social workers. They tend to be nurses. They tend to be someone who has had experience in the healthcare system. They might be lawyers, but they tend not to be. So you're going to have two components to the meeting with the lawyer. You're going to meet with the lawyer to draft the documents. That's the exclusive realm of the lawyer. But you're also then going to have the lawyer bring in their resident patient's advocate. He or she spent years in the system. They know the ins and outs of it. They're very likely not only this, but they're also a this and a that. They're a nurse and social worker. They're a social worker and hospital administrator. The more of them they are, the more skills and levels of expertise, the better they are. And the most important thing that they are is they're your representative. They're looking out for your interests. They're your point of contact for the healthcare system. They're the person you say to the case manager in the acute care facility, here's my patient advocate's number. From now on, you're going to deal with her. That's it. Tell me what the outcome is. And ideally, that patient advocate is going to be there at the emergency room to quarterback the whole process from the beginning to the end. Now, at 3 a.m, that's not likely. But the faster the patient advocate is in the process, taking control of things, the better the expected outcome. You have to shop for the patient's advocate. There's not here's the list and here's who the good ones are. They exist. You haven't the foggiest idea, like looking for a plumber or a mechanic. It's like, who's good, who's not, what do they do, how do they do it? If you are working with a lawyer who you've established a good relationship, but guess what? Most people, it's like, I have as much trouble picking a lawyer as any of the others. So that's no help. So when you go shopping for the patient advocate, you're looking for a permanent relationship. This is not something that you call only when the crisis, it's too late again. You've established a working relationship with this individual. This is why if the law firm has one, it works better, because you're going to sit down at the same time that you're working out the details for these documents, that you're going to work out a complex and minute process by which the patient advocate is going to serve you, and what the expectations and what the process is going to be. And the patient advocate is going to spend possibly more time interviewing with you than the attorney. The patient's advocate's role is to educate and counsel you, is to help you select insurance if you haven't already, if you're not ready for Medicare yet. But then once you have it, the patient's advocate is going to be your source for navigating you through the system. They're going to be responsible for making sure you're making good decisions. They're going to do a lot of the work that the hospital's case manager would have, should have, could have done. Often your patient advocate is going to be reaching out to the next place you're going to go to. And that patient advocate is going to know what the best places are. And they're going to reach out to see if there's a bed available. Because it doesn't matter how good the place is. If there's no bed available, you don't get to go there. The patient's advocate is going to know about long-term acute care facilities and rehab hospitals, and who the home care providers are, and who the good ones are, and the ones to stay away from are. Patient advocate is going to be an essential component if you care about the quality and accessibility of healthcare. A good patient advocate is the difference between positive outcomes in the healthcare system and frustrating accepting what you're given because that's the best you can get, and always thinking there could have been more, there should have been more.
Thank you so much for watching this presentation. I hope you enjoyed it, and I hope you learned something. If you would like to know more about our program and the other presentations that we've created on various healthcare-related topics, please visit our website at phbsp.org, or you can call us at 412-266-8322. Either way, I hope to hear from you. And as always, be safe, be healthy. I'll see you later.